and they will be on the website. Our next speaker on mental health, nursing, and long-term care homes is Dr. Phil Woods from the University of Saskatchewan. Dr. Phil Woods, through 10 years of work at a large forensic mental health hospital, Dr. Woods has worked alongside many nurses and engaged with many individuals who had varying degrees of complex mental health problems. His research has focused on forensic mental health nursing, with his main interest in violence prediction, risk assessment and management, instrument development, and developing practice within forensic mental health nursing. His career includes a number of research projects, and he is currently completing a Saskatchewan Health Research Foundation funded study examining how risk assessment and management is applied within Saskatchewan's forensic and mental health units. Please welcome Dr. Woods.
Probably don't need this today. Yesterday we couldn't see the screen, so we've got a screen in front of us today. So hopefully I won't need the iPad to flick through. So, yeah, I'm Phil Woods. I'm actually a psychiatric nurse by training. I've worked in I first started working in a mental health hospital when I was 18 years of age. I still remember my first job, and that was helping to bathe a 99-year-old lady. And she, all the way through the experience, she sang with her finger up her nose. And it stayed with me for all through my life. But it was a pleasant experience. I spent about 18 months working on that ward before I went in to do my nurse education. Haven't worked in long-term care ever, I have to say. That was the closest I ever got. My wife, she works in long-term care. She's a registered psychiatric nurse as well. She's worked in long-term care all her working life, really. And she works in a long-term care home in Saskatoon now. Works a night shift, so that shift that many people don't want to work, but she likes to work those. So I've been told I've got about 20 minutes, I think, to present something like that. Is that correct? Yeah. Okay. So I'm being optimistic with the slides, I can tell you. But all the slides will be available, so you don't need to take notes. You don't need to write them down. Everything will be made available to you that's in the presentation. I'll probably flick through some of the slides. I'll try and keep myself to time. So first I want to really introduce some fundamental issues that I've observed. I talked about these briefly yesterday. I do apologise for those that may have been in the audience yesterday. There's a couple of slides that I used yesterday, but I need to use them again today. So these are my observations. I didn't even flick the button. It was a mind of its own. Increasing number of clients with complex mental health needs. The mean client age seems to be reducing. Increasing levels of aggression, which we've heard about. Especially client-to-client aggression. My observation is long-term care is perceived as an unsafe environment at times, which is even if it's perceived as unsafe once in a week, it's too many times really for both residents and for staff. And the workforce may not have all the relevant skills and competencies they need, but that's nothing new. I mean, that happens everywhere that you go. That as things change, people don't have the skills that they are required to do their daily jobs. So I'm going to have a very quick literature break here. I was originally asked to look at the literature, so I did. I didn't find much, so I thought I'd share one of them that I did find, which you think you may find interesting. It was a it was a systematic review of the literature looking at aggressive behaviour of nursing home residents, and I expected to see some evidence here. And basically, the review asked three sorts of questions: was the types of aggressive behaviours, the situations where the behaviour occurs, and what strategies do caregivers employ to manage the aggressive behaviour, which I thought might be useful. So there's 21 publications over a 10-year period they found. The bad news is they were very weak study designs, so you can't have a lot of confidence in the results. They did find, and we know this from the literature, varying definitions of aggressive behaviour, but either sort of fell into verbal or physical. What that means is you can't really compare them very well with each other because these different definitions, and I talked about this yesterday, a very large prevalence rate from 1.2 incidents per day to 1 to 4 a year. So varying populations, obviously. Varying types of verbal and physical aggression were reported. There are many, many different types. Probably isn't unfamiliar to you. Personal care of residents are the most frequent context for aggressive behaviour. We know it's close contact. There's also some other situational aspects as well, where maybe people have come together into common areas for at food times and things like that, when people are having meals and stuff like that. Strategies for preventing were behavioural strategies, medical treatment, following written institutional guidelines. So very different strategies, but none you could really have confidence in because they were weak study designs, so you can't really translate them directly into your care environment. They might give you some indications. They talked about a mixture of positive and negative strategies that were used, but they also talked about a lack of information about triggering factors and interactive events during personal care. So you couldn't really tell what was going on during the personal care from these studies. So that's my little literature break, just to show you that I thought there would be a lot of evidence out there and there'd be used to go to the systematic reviews, and it wasn't very helpful really. But you probably know all that already, I guess if you've looked. So my critical issue, probably won't surprise you what I'm going to talk about here. It's going to be about a very proactive solution, which I think that you need to consider, and I'll provide a lot of theory and some of the evidence around that, about risk assessment, risk management. I think that's it's a crucial part of mental health nursing. It's a crucial part of any nursing, of anything that you do. And really focusing, I'm going to focus mainly on violence and aggression, but you can translate most of the things that I'm saying over to mental health as well, because they're very integrated. I don't need this, I'll move it out of the way. So these are the slides that I used yesterday, so just going to quickly go over them to talk about what I mean by risk assessment. It's generally the probability of a bad consequence, something that's going to be occurring at an adverse event or something like that. It involves outcome and probability. There's some outcome involved in a risk that occurs. Many contexts, we've heard about them from the panel this morning already, about different risks that's involved and different outcomes. But it's mainly concerned with the past, now and the future, really. That's really what you're about. It's a guiding force for clinicians, and we've heard a little bit about that this morning as well. And it's very central, I believe, and many other people do, that it's very central to the assessment process. But I always use this quote about, well, this slide about being no magical process. There's no real, this is how you do it. There's different ways of going about it, and there's different strategies, but there's no one magical process. It's a very complex issue. Again, I used this yesterday. It needs to be very systematic, based on the population undergoing assessment. Your population would be, I guess, elderly people and more younger people now, and people with complex mental health issues. So different populations. So you need to consider the population that you're actually assessing. Might be a little bit different the way you assess different people. You break those down into risk factors, and then you manage them through care planning. I've got down here, it should also not only be predictive, because we talked about that yesterday, but it should also be preventative. So your risk assessment should be around prevention. So risk management. This is from a Department of Health document. I've got it on a slide later on, so you can actually go and take this document off the internet. It's freely available. Got a lot of good information in there. States the aim of risk management is first to assess the likelihood of risk events, and then to work with the service users. That's work with your client. The term was service user at that time. I used to hate that term, but that was the term at the time. To identify ways of reducing the likelihood of the harm occurring. Risk management should be based on a plan to reduce the risk of harm occurring and increase the potential for a positive outcome. So it should be positive based. I want to talk a little bit about variables of interest, the sorts of variables that you might look at. There's very static variables, and I think the presentation, I think the plenary yesterday talked about these static risk variables. Those that are very historical in nature. They don't change. You can't do much with them. Somebody's got a history of violence. It's never going to change. They were an offender. It's never going to change. So those static things that will never change. Very hard to work with, but you need to know that information. Then there's the more dynamic risk variables, the ones that you will more likely work with or should be working with. But they must satisfy a number of conditions, and they must precede or be associated with a risk variable, so something that you identify. Maybe they've hit another resident, they've thrown a chair, they've done something that's risky. So they must be associated with it. Must be capable of changing. If somebody throws a chair, you can do something about changing that. It is historical, they've got a history of violence now, but you can do something about the actual action that's going on. So I'm not going to read the rest out because you can read them yourself, but there's a relationship there between between the risk. There's also some from the dynamic factors. There's also some stable ones and acute ones. So those that you'll see that are recurring, that can change over time, but relatively enduring within the person. I.e., you see the behaviour quite a lot, and those acute ones that may be over very short periods of time. somebody might be in crisis, or there might be something else going on in their lives. So split those down into a dynamic and stable and acute factors. I've given some examples of literature here. They actually come from sex offender literature, but these are researchers in Canada that have done quite a lot of work around these sort of risk factors. So you can translate that information to your own practice as well. So you may or may not have heard about these. I mean, every single one of you would have had an actuarial or statistical risk assessment done on you at one time in your life. Everybody has insurance in this room, don't they? Yeah? That's what you've had done on you. Yeah? Your risk. So actuarial is about, it's often done on predetermined, often historical variables that have shown to be predictive of some risk. They're based on the assumption that an individual coming from a population within which a certain type of behaviour is common is more likely to actually display that form of behaviour. So it's population based. It's been highly criticised because people think you can't work with it in clinical practice, and I would tend to agree, and so with the literature nowadays. Clinical, you probably all use this in your practice every single day. Clinical risk assessment. Generally, the research has shown that it's not very good. It's no better than chance. In fact, worse than chance in many occasions. It really looks for explanations of specific behaviours. The reason it's probably not doesn't show very good reliability is because it's affected by many variables within yourself. Your training, your education, what you observe, and things like that. I talked about this. More recently, the results of research have shown some more reliable results. I think that's around training and education of clinicians. So this is what I talked about yesterday a little bit, structured clinical judgment or structured professional judgment. This is where you really incorporate both approaches. A lot better strategy. There's lots of instruments available for you to use now, and we talked about one of those yesterday, and I know you use some in your everyday practice anyway. So structured clinical judgment is really the gold standard nowadays. So it allows for that flexibility. So I just want to talk now about some good practice, and these are some examples of that I've just called upon, and I've used them because they're readily available. You can access them very, very easily. Most of them are available by downloading on the internet, and there's lots of information within them. But before that, I just want to reflect on effective care planning, and this may be familiar, may not be familiar to some of you, but identify priorities of care, obviously effective care planning. The goals should be stated in clear, concise and measurable terms, accompanied by a time frame. Any good risk assessment will do that. You need to have some time frame which you're going to remeasure. The needs and problem statements around the risks really need to be written in terms of some of the following: what, when, where, with who, frequency, duration, antecedents, behaviour, consequences. You've probably heard all familiar with these terms. Very, very, very widely used within mental health nursing. Very important that you reflect on your care planning process. When you identify your needs or problems around the risk, you really need to collect your assessment data, which we've talked about. Be very exhaustive, as much data as you can hear. I've heard some conversations, I think it was yesterday, where that the information isn't given to you. You don't know about somebody's offending behaviour or something else. I mean, you've got to collect as much information as you can from as many resources as you can. It's also useful to look at the severity, the frequency, intensity, duration, the risks, again the intensity, behaviours and consequences around the need or prioritisation that you're actually working around. And then you'll look at the prioritising that, about the judgment of the urgency, the subjective distress in the individual, or even in the nursing staff or the care staff in the home or the other residents. The motivation and how achievable it will be. There's just a little bit of reflection around about good care planning issues. Positive risk taking. This is a term that appeared in the literature around about the early 2000s, and it talked about really, and I've got a quote up here from Morgan, and there's a very good document, that training guide, and I'm going to reference some of this in a moment. It's about weighing up the potential benefits and harms of exercising one choice over another. This means identifying the potential risks involved and developing plans and actions that reflect the positive potentials and stated priorities of the service user. So it's focused around the client. It involves using available resources and support to achieve the desired outcomes and to minimise potential harmful outcomes. Positive risk taking is not, I'm getting the 5-minute warning here, I think. We'll see how we get through the slides now. I'll not read the rest. I'll go through to another slide. You can read it yourself. I told her I was being optimistic. Mike Doyle, he's a nurse practitioner that I've worked with for many years. He asked these 7 key questions. It's an old reference now, but he's done a lot of work around risk assessment, risk management. He's a practicing clinician. He has a PhD. He's a very effective practitioner in risk. He works in forensic mental health. These are some of the things the questions he said you should be asking yourself. So I'll leave you to reflect on those at a later date. These are some resources. I don't even know if, but this is a particularly good resource. It's by Tony Ryan. It talks about very different diagnoses and about managing crisis and risk in mental health nursing. The other book is one that I edited along with another colleague, so there's some resources in there. So some interesting resources for you to consider. This is another resource. I'm not going to go through it too much. It's about a 200-page document that's available if you just search for this title, and it has a large literature review on risk assessment, risk management in mental health nursing. It was done by the Institute of Psychiatry in the UK, and they made 8 good practice recommendations. And I think some of that will be very applicable to your work. Morgan, I talked about this before, and he talked about a risk assessment process. He talked about risk analysis, identifying hazards, the evidence, victims, antecedents, the same words I've been using before. So you see the same sorts of words coming through the literature and the resources that's available. Again, this is actually a training pack. You can actually buy the training pack. You can actually have the slides in there to use. And things haven't really changed. I mean, the same principles apply. So I'm just going to flick through these slides very briefly because they're all available. But these just go into some more detail about the sorts of things that you should be looking at when you're looking at personal situational factors. So really it's really a functional analysis of what drives that behaviour. Historical data, we talked about that before, but it includes all relevant evidence. I know you've seen more and more offenders in your care homes now as well. It's because offenders get old as well. I mean, but sometimes their offending behaviour doesn't go away. Again, possible victims and the opportunities for accessing those victims. They're accessing the sorts of behaviours that they actually display. The triggers, these are really important, the triggers. What triggers the episode or the aggression or the mental health issue that's going to be going on. And any external events that might be relative to those. And of course observable changes in behaviour as well. So this I'm not going to flick through all these slides because there's a large number of them, but this is an extremely useful document. I might just flick through the slides as I'm talking about it, but it provides it was provided by the Department of Health, and it actually talked about some good practice points in effective risk management. And I've provided all these on the slides from the document. So it's readily available if you can download it. It's got some really good tips and there for good practice. It talks about building on the user's strengths, about working with them, working into professional teams. It talks about the plans, how to develop those. Really, really good resource. My contact information. I mean, the message I'm giving really here is, I think one of the ways that you can address some of the mental health issues is about through your assessment and your planning. I tried to drive that message home yesterday. I've tried to drive it home again today. It's to me, it's complex. It needs a lot of training, education. You can't just expect people to have those skills, and that's another, I guess, a crucial point. So I'm going to end there anyway, and I'm willing to have any discussion or questions. I guess that's the plan. I guess now is it? Yeah. Yeah.
Walked up. I have a question for both Elizabeth and Doris. Was it Doris? Dot. I wanted to ask both of you that are coming from long-term care, because we're with CCAC. So when I heard CCAC, my ears perked up a little bit. But I wanted to find out, with the client population that you have in your homes currently, in terms of assisting the case managers that are doing these assessments, what kind of tips or information would you be able to share to be able to make the assessments a little bit more richer so that it helps you when you're looking at those applications to be better informed? And then the second part of the question was just for Elizabeth in terms of accessing the specialized behavioral units, because I know in Mississauga-Halton we have a behavioral unit. So are you working with, Toronto Rehab Institute, Baycrest, to get that particular population to those areas?
With regards to CCAC, I mean, a lot of the challenges is the fact there's a lot of inconsistency in the application. When we look at the application, we look at the referral. Most importantly, we look at the MDSRI. And when we as an interprofessional team, we look at it, we look at the inconsistency. And that is when we get the flag. And when that flag happens, again, we ask CCAC, could we have some more information and so forth, but that sometimes too is a challenge, and especially for St. George, for the fact that we have a small wait list. Currently, right now, we have a wait list of only 16. Majority of them are ward rate, a lot of inconsistency in the finance, and so forth. So it becomes a major challenge. And again, too, for me is advocacy. So for me, working with CCAC in Toronto, what I'm doing is I speak to the manager directly. And I set a precedence and say, well, this is the home now. I'm unable to have the challenging type of clientele that I have now. And that's a lot of work. But I'm continuing to do that, and I see a positive change. So I'm seeing clients now with less of psychiatric issues, which is a good thing, and that's working with CCAC. CCAC is not the enemy. The information that you receive is from the outside clientele, and you document what you get. But it's up to us as a home to look at inconsistencies, which we do, and we speak with CCAC, and I also too get my partnerships that are out there to assist.
I just want to mention a couple things about CCAC. One thing, if they don't know the homes, they should tour the homes for sure. Transparency, we're part of the circle of care. So share everything with us, and we do have problems with people that are incarcerated and we aren't told, and we're seeing behaviors. Behavioral mapping is really important, and sometimes we get that in our referral, and sometimes we don't. Finance, as I mentioned, is huge. It's really huge. Going on site and doing an assessment, don't be offended. We really do like to do that if we have the time. It's a resource issue, but we see it with a different set of eyes, and we know what we can cope with and what our behaviors are at that time in the home. So we want to be part of the solution too. We want these people, we want to keep our beds filled, but we have to work together. That's basically what we're looking for.
Any more questions? Okay, well, thank you very much to our panelists. I also want to thank the session sponsor, Omni Healthcare, for their support. You will have evaluation forms that will be sent out after Research Day, and we really welcome your comments and suggestions on those forms. Once you complete the form, you will have access to all of the presentations that over the past 2 days. A reminder that the closing plenary session will begin I believe next door at 11:15, so we have time for a short break. And following that plenary session, the networking luncheon will be served in the foyer on the lower level at noon, with seating available in Toronto 2. There will be an OLTCA active member session during lunch in Toronto 2 at 12 noon, and an OLTCA members meeting at 12:45 in Toronto 2. So thank you very much, everybody.